Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. You are listening to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today I'm answering some of your top fertility questions. I'm a board-certified OBGYN and REI, and I talk about fertility, your body, your health, and your hormones all the time. This podcast exists so that you can become a better advocate for your own body, you can understand how it works, and you can understand your fertility journey a little bit better. One of my favorite episodes are when I get to answer your questions, and we have a few different ways which you can ask them. But if you are a newsletter subscriber, you do have exclusive access where you can ask questions and yours get answered on priority. So sign up for the newsletter at nataliecrawfordmd.com/newsletter. Today's questions are coming directly from our newsletter subscribers, and some of them are really good. So as compared to voicemail episodes, you're going to hear me reading out these questions and then I will answer them. Other ways where you can ask your question can be on Instagram on Monday at nataliecrawfordmd. There'll be a question box and some will be answered right there on Instagram. Some will be answered on regular podcast episodes. And you can also call and leave a voicemail. Voicemail episodes are some of my favorite. The voicemail for As a Woman is 657-229-3672. Share what's going on, share your question. I love fertility Q&A because sometimes you don't know what questions to ask until you hear somebody else bring it up. With that, we're going to dive right into our newsletter Q&A exclusive episode right here. Hi there, I was on the birth control pill for 13 years, and many of these years I did not have a period. Now it has been 2 years off the pill and my periods are irregular, meaning I had to take progesterone 1 month to stop the bleeding. My cycle length can vary between 29 to 43 days. My husband and I want to try to conceive, so I went to see my OBGYN, who wants me to start Clomid due to not ovulating. She never explained what she thought was causing me to not ovulate. I'm assuming I have PCOS, but didn't order any labs, any ultrasounds, any studies. Wondering if it's okay to start the Clomid without this testing, and is it safe to start when my period comes if I am out of town on a hiking trip? Thanks in advance. This is a really good question that hits a few different ideas. Number one, yes, being on the birth control pill for a long time can be a really great way for preventing a pregnancy, and it is totally fine if you are taking it continuously where you don't have periods. That's not harmful at all. However, we have to remember that being on the birth control pill prevents your body from having hormonal communication between the brain and the ovaries, and the ovaries are essentially in a quiet, sleepy state. They have to wake up and respond and remember how to ovulate. Some people can have underlying brain ovary issues. This can be PCOS or hypothalamic amenorrhea or premature ovarian failure, or even thyroid disease or prolactin abnormalities. And these things can cause you to have abnormal cycles. And when you're on the birth control pill, because your hormones are not controlling the bleeding pattern, the pill is, you have no clue that some of this may be going on. Now you stop the pill and you have this irregularity, and what is happening? A lot of the answer is going to depend on your age. That's going to be my question. PCOS is one of the top causes of not ovulating. In polycystic ovarian syndrome, if we're going to simplify a very complex disease for the sake of this answer, you have a lot of eggs. And when you have a lot of eggs, each egg grows inside a follicle. Remember, the brain sends out follicle stimulating hormone, or FSH, which is well named to get a follicle to grow. The brain sends out some FSH, and that signal is supposed to get one egg to grow. But if you have a lot of eggs, the FSH is going to get diluted amongst all of them, and then you're not going to have that acute, predictable, reliable response because it's too dilute of a signal. And it might take longer exposure to the FSH to actually see the egg growing. Also, when you're not growing that egg, making that high level of estrogen, the ovary tends to get bored, and that's when it can start making testosterone, which predisposes you to insulin resistance and abdominal weight gain and acne and hair growth on your face and hair loss on your head and some of those higher testosterone symptoms. When it comes to treatment of PCOS, Oral options for ovulation induction are typically the first line, and these two medications are Clomid or letrozole. Clomid works by blocking the estrogen in the brain, and so your brain says, OMG, there's no estrogen, and sends out a signal of FSH. Letrozole works similarly. I like to call them cousins, but it eats up estrogen in your bloodstream. So essentially, you still interpret that there is some estrogen, just the level now feels lower. And the brain is supposed to respond and send out some FSH. So if we know somebody has an ovulation, and specifically if we know that it's PCOS, it's not wrong to say, here's some Clomid or letrozole and see if you ovulate. However, it can be really frustrating and it can be the wrong thing, especially if you're older or depending on the size family you want, or if we do not have an actual diagnosis of PCOS, because what if there is something else causing your irregular cycles? So in my mind, there's a difference between knowing why your cycles are irregular, having that workup done, and having to have the full fertility evaluation done. Meaning, I would want to know that it's PCOS. So that can be diagnosed typically with an ultrasound. Maybe you have clinical findings that are significant enough that aren't given to me in this prompt, like the acne's gotten really terrible and the irregular periods. But there also is blood work, thyroid, prolactin, AMH. So that's in my mind, I kind of want to rule out that there's not a low egg count, a thyroid or prolactin causing some of this irregularity, have an ultrasound that looks like it's PCOS before just starting medication. Now, depending on your age, what I might do for somebody who's 24 and 37 are really different in this scenario. Because if you are older, or if you're in your 30s and you want multiple kids and this is your first, I want to make sure I have all the pieces of the puzzle. So that would be the complete fertility evaluation, adding on a tubal evaluation to make sure your fallopian tubes are open, and a semen analysis to make sure your partner has sperm. Because two things can always be true, meaning you could have PCOS and his sperm could also not be great. And you would hate to feel like you wasted your time using oral medications that were never going to work. For the most part, Clomid and letrozole have pretty low risk rate, meaning the number one risk is going to be multiple pregnancy. So you have about a 8 to 10% chance of having twins if you use this medication. I always think it's important to understand, how are you confirming it worked? Remember, working doesn't mean getting pregnant. We want you to get pregnant. But working, the medication doing its job, is you ovulating. Are they checking post-ovulatory blood work? Are they checking an ultrasound? Are you checking an ovulation kit? How long is too long? Because not everybody responds to the same dose. So I think that's an important question. How do we know if I ovulated and how long am I going to do this? Also, letrozole is drug of choice for PCOS. It's associated with a higher live birth rate. So if we do think we have PCOS, then letrozole should be the medication that we're using, not Clomid. Clomid can cause a higher rate of having ovarian cysts, a thinner lining, more overall side effects, and has a higher rate of having too many follicles in my experience. So I think there's a balance here in just saying, hey, here's some Clomid, give it a go, and come back if you don't get pregnant, versus, is that really what's going on? Have we evaluated your irregular cycles? And what is your big picture plan? Because maybe you do need a full fertility evaluation, or how are you going to track response, or how many cycles are you going to do? All right, the next question is, can we get a fertility workup before age 35 if I've not been trying for a full year? I think it's really important to understand that the diagnosis of infertility is made by the absence of something happening. You don't have a pregnancy. After X amount of time, now you have infertility. Under age 35, that number is 12 months. Over age 35, it's 6. The reason why these numbers exist is because that is when the odds of finding something wrong increase, and it becomes worth the cost of doing the screening on a population-based level. However, for an individual person, I think it can always make a lot of sense to do testing earlier, specifically if you have warning factors, you want a bigger family, or just understanding that most people who get pregnant will get pregnant within the first few months trying. The vast majority will get pregnant within 6 months, and only a small percentage will get pregnant in those next 6 months. So when we look at the difference, if you're not pregnant at 6 months to not being pregnant at 12 months, only about 12% more people will get pregnant in that 6-month time period. So it's not a huge number. This, to me, I always think that you deserve information about your body. If you ask your OBGYN, hey, can I get fertility testing? Well, many of them are going to say you don't need it yet, you haven't tried long enough. That is okay, that's true. If they're going to go diagnose infertility, you've not met it. Some people will be more proactive, especially if you pose the question right. I know we're only 32 and we've been trying for 6 months, but we really want 4 kids and we're getting started a little bit late for that goal. So can I go ahead and maybe do some testing, because if my egg count is low or the sperm is abnormal or my tubes are blocked, we'd rather do IVF sooner or later. The other way to circumvent this now is you can just schedule an appointment with a fertility doctor for testing. You can just call my clinic. You can call whatever clinic's close to you and say you want to have fertility testing done. You'll get a new patient consult. They'll talk you through the basic testing. Might it be overkill? Sure. Maybe you do testing, everything's normal, you get pregnant the next month. But then then you're not wondering if something else is wrong. And then you're not in the position where some of my patients have tried for 12 months, 18 months, and then find out their partner had no sperm or their egg count was very low. And they wish they'd had the opportunity to intervene on that knowledge a lot earlier, but somebody denied them the opportunity for an evaluation. You can't make decisions on data you don't know. So it is up to you to make that decision to get the testing done. Normal fertility testing is going to be, how many eggs do you have? Not that having a low egg count means you can't get pregnant, but it helps frame your reproductive lifespan. It can be a warning sign for other things. You can see low egg counts with endometriosis and autoimmune disease, and it can represent getting a lower number of eggs with IVF or egg freezing. So if you were going to do that technology, we would want you to intervene sooner. We would do testing of your fallopian tubes to make sure your fallopian tubes are open. It becomes more important if you've ever had abdominal surgery, pelvic infections like gonorrhea, chlamydia, or any of the endometriosis warning signs like painful periods, pain with intercourse, or if you've had any ruptured cysts, any potential bleeding internally. Extra important to make sure your tubes are open. And then sperm. Sperm changes every 3 months. Just because your partner maybe has a 3-year-old kid, it doesn't mean the sperm is fine now. And I definitely will have patients come to me. We'll talk through their history, make sure there's nothing else concerning, do this testing, sit down, maybe it's all normal. And we say, hey, now that we know this is normal, we feel comfortable trying another X amount of time. 3 months, 4 months, 6 months, depends on their full situation. And then we should advance care sooner, and we'll do this. Often we find something wrong. I had a patient this month who I saw who's only been trying for 3 months, but came in, felt like something was wrong, and sure enough, has a really low egg count and does have some other things going on that now we are going to intervene much sooner than that 1-year mark. So this is one where I think it's important to remember that infertility as a field is a reactive field. You must prove something's wrong before people are going to say, let's do this. It's not a preventive medicine field. We can argue about that. I think it should be. If having kids is a life goal, a major life goal, like it is for so many people, then we should be more proactive about this. But we have to remember these definitions, this evaluation, this was all determined in a world prior to egg freezing, prior to easier access to IVF treatment. And so we had a lot less we could do to help somebody. We didn't even have AMH testing. So the world's a different place now. And I always think that's really important to keep perspective on. Can you please share information and knowledge regarding fertility options for women with a balanced translocation? So rewind a minute, because most people don't know that they have a balanced translocation. Number one, so sorry that you do. I know what this means. A balanced translocation is when you have an uneven distribution of your chromosomes. You have them all. So if we like to imagine, I use the analogy of imagining that inside the egg, your chromosomes are in perfect line. And it's like having kindergartners standing in a line. We know that the longer they stand there, the increased odds that somebody's going to get out of position, and that is going to increase the chance of having a genetic abnormality when you go get pregnant. Well, having a balanced translocation is like having somebody have an arm swapped with somebody else. And the odds that these are going to divide and that person and their arm are going to be on the same side start to decrease. And that's a simplistic way of saying it, but essentially 2 of your chromosomes, pieces of them have swap spots. In your body, in your life, it doesn't matter, because your body doesn't care where the chromosomes are as long as you have them and that you have the right number, that you don't have too many or too few. When you suddenly have something swap positions and then your egg goes and has to get fertilized by sperm, your chromosomes actually divide in half before you ovulate, because your genetics are 46XX and an egg is 23X. So your chromosomes are held in perfect position and they then split, so you have just one half of them. And if two of them have partial portion swapped, they're going to split unevenly. If the egg has both pieces, so it has all the chromosomes it needs, then it's fine. That's what you have. But if the egg ends up unbalanced, then that is not going to be compatible with life in the majority of circumstances and actually causes miscarriage. So when you think about somebody who's got a balanced translocation, this is classically determined in a recurrent pregnancy loss evaluation. So you're having multiple pregnancy losses. The typical evaluation is going to include clotting factors, anatomical evaluation, looking at a karyotype, and autoimmune disease. When it comes to the karyotype, one of the things that we're looking for is this exactly. And this is a balanced translocation, could happen in either partner. So if you are having recurrent pregnancy loss, both you and your partner need to have a karyotype drawn. One of the most confusing things is that somebody can have a live birth because it can be balanced. So this is a circumstance where you usually would have 1 live birth to 3 losses. And it can be a really hard thing because there's nothing you can particularly do about it. Meaning, I can't take a medicine, I can't fix the eggs, I can't fix the sperm. You can do IVF. And IVF is the recommendation because it's not just bad to go through a lot of miscarriages, it can actually hurt your future fertility. It takes time, your uterus has to recover. You can only have so many D&Cs or procedures inside your uterus. It's sensitive and it can lead to damage. So when we look at this, if we find out this is what's happening, we are going to recommend IVF with genetic testing specifically for aneuploidy. So do you have the right chromosome number? But then also for what's called PGT-SR, structural rearrangement. So instead of just making sure you have the right number of chromosomes, they're actually looking to make sure they're in the right spots. And then you would only transfer embryos that are balanced. So any of the embryos that are aneuploid, just have the wrong number, or are unbalanced, don't have all the pieces of the chromosomes, those would not be transferable. And everybody's at a little bit different rate, but in reality, this is going to skyrocket the rate of abnormal embryos in your pot. It's a little tough because you have 2 things. Whatever your age-related chance of losses, just based on aneuploidy, people getting out of line, and then you take the hit for the structural rearrangement or the translocation. So I prepare people, you are often going to need multiple cycles, even if you're young, just because you're going to take a double hit on genetics trying to find those normal embryos. That said, it is a much more efficient way to build your family, can save you from a ton of heartbreak and from procedures and D&Cs and ultimately risk. So it is the strong recommendation. All right, this question is obesity a reason for infertility? I'm currently at a BMI of 32, 5 kilos away from a BMI of 30, and can only be referred to a fertility specialist once I am that weight, as, quote, my obesity may be causing my infertility, end quote. From what I have researched, obesity can increase risk during pregnancy. However, there are varying degrees of actual obesity compared to just using BMI alone. Sad face. I get this. And if this is delaying just even getting an evaluation, that can be so hard. And to be honest, that's not something I've heard of. I've definitely heard of BMI caps on certain treatments, but not just for an entire referral or for an evaluation. It's a complicated question because obesity can cause metabolic issues, and overall having extra fat cells can be inflammatory. Having extra fat cells can cause a higher rate of metabolic syndrome, having insulin resistance, higher cholesterol, vitamin D deficiency. You have a higher risk of endometriomal cancer if you're not having regular periods. And all of those things can be true. The thing I like to think about and how I reference obesity when it comes to fertility, plenty of people are overweight and get pregnant fine. There's definitely people who are overweight and it is contributing to another factor. If we remember that in order to get pregnant, we need your periods to be regular, Your fat cells, everybody's fat cells, make estrogen. And that estrogen also talks to the brain, just like the estrogen from the ovaries. So when your estrogen drops because you didn't get pregnant that month and the corpus luteum dies, the brain is supposed to sense time to grow a new egg and send out a surge of FSH to get that egg to grow. However, when you have fat cells also making estrogen, it is static interference coming into the brain where it doesn't sense your estrogen being as low as it actually is, meaning it doesn't send out as strong of an FSH signal. You can have delayed or anovulation associated with this obesity pathway, in addition to insulin resistance contributing to miscarriage and making it harder to get pregnant. So certainly there's some pathways where obesity, regardless of the source, can contribute to making it harder to get pregnant beyond just pregnancy outcomes. So I think that that's important for us to understand. Most places that have a BMI restriction on treatment are because it's very high, like a BMI of 50 to get pregnant or a BMI of 40 for anesthesia for an egg retrieval. But having that BMI level before you can even get referred is really, really tough. And I don't know if that's just local or the country you live in contributing to that, but that alone would not be something that I would just say is completely causing your infertility, especially when it's not a profoundly high BMI. So sending lots of love, hoping you can get answers. Certainly for anybody, if you lose some weight and that fat estrogen drops, it's easier for the brain and ovary to communicate again. And that's why we've seen so many people having Ozempic babies and getting pregnant once they lose some weight. But there's certainly more to the picture. Two things can always be happening, and I definitely recommend you get an evaluation as soon as you can. Lots of love. I heard you say that getting flu or a bad virus can decrease sperm counts. How long does this take to recover? I know that typically sperm regenerates every 3 months, but if we are trying to get pregnant, does this mean we should take a break from trying? That would be extremely frustrating, especially since autumn and winter is coming and this is the season that people get sick. This is a really good question, and I think it underscores the fact that sperm are super fragile. Remember that a sperm is a head that carries DNA and it has a tail, and its job is to swim, protect the DNA, and be able to fertilize an egg. So when we start thinking through what is going on here, what I think is important to remember that, men make 1,500 sperm a second, millions and millions of sperm a day. And that sperm shape, sperm production is very influenced by the world around us. So yes, when somebody gets really sick, they are going to see a decrease in their sperm counts. We saw some men after COVID go to azoospermia, or almost no sperm, or very abnormally shaped sperm. And likely this is a correlation with the huge inflammatory response seen with COVID, but any disease that makes you have a huge inflammatory response or makes you really sick, your body is going to divert resources, and it can take some resources away from making gametes like eggs and sperm. What I think is really important here, yes, sperm regenerates. So you're going to recover, it's going to make new sperm, and that we haven't seen this associated with a higher rate of pregnancy loss or birth defects. I would not recommend or tell somebody they need to stop trying. I wouldn't say, oh, your husband had the flu, now you can't try for 3 months. I agree, that is frustrating. I do think it's important if we think about maybe you're doing IVF. Now I need the best sample of sperm ever. If your husband gets really sick a month before your IVF date or while you're undergoing shots, that's worth a discussion about, does this make sense? Especially before you start your medication. So if your partner is really, really sick, he gets COVID, he's down for the count, and you're supposed to start your IVF meds in a couple weeks, you should have that conversation, because maybe it makes sense to recheck the sperm before you start, make sure it's okay, or delay the cycle. Because what we don't want to do is go through, have really bad sperm, have really bad fertilization or blastulation, and then come back and say it was the sperm's fault, we need to wait for it to be better, if maybe we just should have done that to begin with. But your care team doesn't know what's going on unless you tell them. And so this is a discussion where I wouldn't stop trying, but I would definitely bring it up if we're doing fertility treatments. Okay, moving on to the next question. And this is going to be the last question for this episode. So again, these questions are all coming from the newsletter. So you can subscribe to the newsletter at nataliecrawfordmd.com/newsletter. You'll see some exclusive questions answered there. You can ask questions. You'll also get the TTC Starter Guide, some of my favorite recipes, fertility in the news. It's not spammy. We actually put a lot of time into it, so go and sign up. You can also ask your questions on Monday on Instagram at nataliecrawfordmd. Some of those questions will be answered there on Instagram or here in other episodes, or you can call and leave a voicemail. The voicemail is 657-229-3672. We've been working to group those questions together in themes, so if you ask one, we are getting to it, but that's also a really excellent way to get a question answered. This question is, do you know what causes endometriomas? I have a few endometriomas and I just want to understand more. An endometrioma is an endometriosis cyst. So my simple way to describe endometriosis, also not a simple disease, is we know it's an inflammatory disease and it's on the autoimmune spectrum. If we like to imagine that your body is reacting abnormally to a normal process, there's actually a few different theories about what can cause endometriosis, and I group it together like most autoimmune diseases. There's a genetic predisposition and probably some environmental exposure which kicks you over. When we think about endo, I like to think about have your period. When you're having your period, you're shedding the endometrium or the lining of the uterus that you grew that month. If you can imagine that uterus cramping and contracting to try to expel that endometrial tissue, some of those endometrial cells are also going to come out the fallopian tubes. That's called retrograde menstruation. It itself is not a problem. Meaning if I go do surgery on somebody and she happens to be on her period, I can see some menstrual blood in the abdominal cavity, not an issue. The issue is the actual abnormal response that happens. So your body sees these endometrial cells regardless of how they get there. There's another theory that these cells can go through the lymphatic system. Neither here nor there how these endometrial cells really got outside the uterus, but the fact is your body views it as abnormal and sends out your immune system to attack it. So when it starts to attack it, then what is happening is that you start to have this immune response which can cause inflammation, pain, eventual scarring. When it comes to the process of an endometrioma, imagine that with an endometrioma, you are ovulating. So you have an egg that is growing within a follicle inside the ovary. We know that that follicle has to rupture in order to let the egg come out. From there, what is happening is that follicle reforms and becomes the corpus luteum, which is what makes progesterone. And it really has a lot of blood supply, and it's a very nourishing environment because that's what the ovary needs to make progesterone. But endometriosis cells can get inside that follicle while it's open and the egg escapes, and then the endo loves it and it's never going to leave. You cannot get rid of an endometrioma with any way besides surgery. Once it's there, it's there. It can really cause devastating consequences, can be destructive to the endometrial tissue, can drop your egg count. We actually don't recommend surgical removal most of the time. If you're doing IVF, we like to do IVF around them because they do drop your egg count and you can lose some good ovarian tissue. But that's a complex decision based on exactly where it is and how big and your personal anatomy. However, if you're trying to say, how do I prevent getting another endometrioma? It's going to go back to not ovulating. So being on a type of hormonal suppression not to ovulate is going to be the way to prevent more from coming. Won't get rid of what you have, but every time you ovulate, that follicle ruptures. That is now an opportunity for endometriosis to get inside there and form an endometrioma. And so this is why you might hear people say, okay, you have an endometrioma, you are going to have surgery for endo, you're not wanting to get pregnant, you should go on birth control or Lupron or progesterone or something in order to prevent ovulation so that you're not making that endogenous estrogen, which is stimulating the patches of endometriosis, yes. But also, if you don't ovulate, you decrease the opportunity. There is no opportunity for an endometrioma to form. So it's complex based on where you are in the state of life that you're at. Obviously, you can't prevent that if you're trying to get pregnant, so that's what makes it really, really tough. But overall, these are fantastic questions, and I love them, so keep them coming. Remember, you can ask questions on Instagram at nataliecrawfordmd on Mondays. You can sign up for the newsletter, nataliecrawfordmd.com/newsletter, or you can call and leave your question on the As a Woman voicemail at 657-229-3672. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.